Hello, everybody. I hope you can see me or see us, and at least you can hear us. I welcome you to the session on neonatology, and we are glad to know that you are members of this video session of the EIP this morning. At least in Europe, it is the morning. But we know from the former conferences that the attendees of the EIP meetings come from across the whole world. And that, of course, is the charming peculiarity of the EIP meetings, that we have colleagues from across the whole world. And of course, in 2020, it's not so easy to be aware of the fact that we are all members of the same academic society, of the same profession, so to say. But at least in mind, we are with you wherever you look at the screen at this moment. And we are all glad that you joined us through this video session meeting. Now, we have a meeting of 2 hours now, and we have a presentation that will be given by Professor Maria Roberta CILIO from Louvain in Belgium. She will talk about seizures in the neonate state of the art. And after that, we have a talk given by Dr. Hannah Petersen. She is a consultant in Berlin, and she will talk about update on sedation and analgesia in neonates. The speakers will introduce themselves later on, so I can leave it at that, and I can now switch to my own presentation, and I hope that you all can now see the presentation on your screen. Now, my topic is feeding problems and tongue tie, and of course, since this is a neonatology session, I will focus a little bit on breastfeeding. And the other reason for restricting the issue to breastfeeding is that you are all aware of the fact that feeding problems are most prominent in the first months of life, and later they usually vanish. Now, sorry, I can't switch to the next. Yes, these are the next slides. This is the content of my talk. I will talk a little bit about obstacles to breastfeeding, the relevance of lactation consultation, causes of breastfeeding, and a little bit about tongue tie. I will show you a study. But I couldn't give this lecture without talking first a little bit about some elementary issues that you as a neonatologist or pediatrician obviously know, all of you. But let me at least summarize in a few sentences the breastfeeding benefits for infants and mothers. We all know that mother's milk provides the ideal nutrition for babies, since it causes, besides many other ingredients, important antibodies to reduce infectious diseases. And among these diseases are so important ones like necrotizing enterocolitis and preterms. We all know that also, for reasons that are unknown today, breastfeeding also reduces the risk of sudden infant death syndrome. Later in life, the infant or the child has advantage in having fewer allergic diseases, bowel diseases, later lower prevalence of diabetes, or even serious illnesses like childhood leukemia. And we all know that, and this is also a very important reason worldwide to promote breastfeeding. The wide gain of children is much better when you breastfeed. You all know that, I'm sure, but I always think that it is very important to recall these benefits, because we are often engaged in discussions with mothers who probably are a little bit reluctant about breastfeeding. And some even feel that children are smarter if you breastfeed them, but if you, there's a studies, if you look at the studies, it depends a little bit on the socio-demographic pattern and a little bit on the income and things like that. At least we all, as a pediatrician, should be aware of the fact that one very important reason is that breastfeeding reduces the risk of child neglection and abuse. And at this point, we all must be aware of the fact that when we talk about breastfeeding, we do not only talk about the ingredients of mother's milk, but we also talk about an intimate act of breastfeeding, as demonstrated here in this symbolic picture. Now, there are also many, many benefits for the mothers. You all know that uterus contraction, loss of weight after pregnancy helps the mother to get in a healthier state. Breastfeeding reduces very serious illnesses that are summarized here on this slide. And I think that in the immediate period after birth, also the lower risk of mother's depression is a very important issue to address. And at least we should also aware of the fact that breastfeeding saves time and money, and this may be an issue worldwide. Now, of course, this is the reason why the WHO recommends exclusive breastfeeding for 6 months, and this recommendation is worth for every country in the world. However, we must notice that the rate of lactation varies greatly. If you look at data that ask mothers, did you ever after birth breastfeed your infant, then the rate of positive answers varied between 34 and 100%. And this is not even the question for what is, of course, more important. Did you breastfeed for the whole period of 6 months? And we must assume that this rate will be much lower. Now, there are only very, very few reasons not to breastfeed an infant. And one of these reasons, of course, galactosemia. And the other reason is a short list of serious infections, such as active and untreated tuberculosis, herpes virus with attached regions of the breast, and a very rare disease, the human T-cell lymphotropic virus. But these are very rare instances, and there is but there's also a little dispute of about more prevalent diseases such as hepatitis C and B. Most institutions will allow to breastfeed an infant after hepatitis B active and passive immunization of an infant of a mother who is hepatitis B positive. But there is still a little bit of concern about the situation for hepatitis C, where some institutions recommend not to breastfeed, at least if the mother has cracked nipples. Now, what is the situation for HIV? HIV, at least in Europe, was former thought to be a stringent contraindication for breastfeeding, but nowadays, if the mother is in a good condition, takes her antiretroviral drugs, is in continuous medical observation, and has a low virus load, breastfeeding is allowed on an individual decision basis. So there remains only a very, very short list of other situations such as cancer, therapy, toxic drugs, illicit drugs of the mother, or severe wasting illness, which probably is a reason not to breastfeed. Leaving it at that, we can now look at the situation in the maternity units. What is the reason? Why do mothers not breastfeed? Let us take over the perspective of a mother. We know that almost 30% of mothers say that breastfeeding is difficult, and I know from relatives or friends of mine that bottle feeding is easier, and this might be a matter why they refrain from breastfeeding already in an early state of motherhood. Of course, we all know that the first week of motherhood is a tough time. There is a lot of change in the personal situation and also in the medical situation of a mother. There might be a painful breast swelling or an engorgement in the breasts, and milk supply is probably not yet very well established. But there are also mothers who claim that I knew I wouldn't breastfeed long anyway because I go back to work soon. And this probably is an argument that we could counteract by addressing issues such as that we know that every drop of breast milk is of benefit for your infant, and even if you cannot breastfeed for a long time, try to do it at least for a little while. Now, the relevant issue that may be of a real concern for midwives, obstetricians, nurses, and neonatologists is that many mothers claim that I didn't get the support I needed. And I will address that a little bit in the next few slides, because this is a challenging issue for all of us who are convinced that breastfeeding is very important. Now let us first look at the issue, why is breastfeeding more difficult for infants and mothers than bottle feeding? We know that the suckling mechanism at the breast is much different from the mechanism when the infant is bottle fed. We see that the infant sucks in the whole mamilla, and then the mechanism is not the same as for a person who drinks liquid through a straw. It is not an issue of producing a vacuum, but it is instead milking mechanism with a peristalsis along the tongue from the the top to the bottom of the tongue muscle. And this is obviously more difficult for infants than to be bottle fed. But the reason that infants who fail successful breastfeeding may be successfully bottle fed may not be an argument to refrain from propagation of breastfeeding. Now, what is the objective reason for poor breastfeeding? If you look at studies that have done on this issue, it is a cesarean section or a traumatic spontaneous birth that makes the mothers feel unwealthy and they do not come into lactation at time. It may be also a severe illness such as preeclampsia or anything like that. But one thing that will appear later in my presentation, a very important reason is that mothers lack experience. It is probably the first child, and this mother definitely needs help to come into lactation. Some claim that they tried to breastfeed in former pregnancies, but they failed, and some even feel guilty about that. And it is, I think, a different, an important task for lactation consultants and neonatologists and obstetricians to motivate these mothers to try in this pregnancy to start breastfeeding. Of course, sedatives and situation post-anesthesia does plays a role, and in particular, mothers who delivered by section may have a delayed milk let down and an empty breast, which is of course not a permanent problem and can be overcome by adequate consultation. The massive breast swelling and engorgement in the first days was already addressed. And the situation of the mother who refuses to breastfeed her infant is probably very prominent in those that experience bleeding nipples. And bleeding nipples, in fact, can be a situation that is caused by a tongue tie, which will be addressed in a few minutes. Now, they may be, of course, also reasons that come from the infant. The infant may be weak because it is a late preterm. It has an intrauterine growth restriction. Some of the infants may be on the NICU because they have a severe illness, but also the NICU, it is not impossible to breastfeed an infant. You must create the atmosphere. You must be willing as a whole team to promote breastfeeding, or even in this situation that is of course not so familiar for the mothers. The infant may be a little bit drowsy because the mother has had anesthesia. Mother may have had tranquilizers or other drugs that lead to drowsiness. But we all know that even the normal physiologic jaundice may make the infant a little bit weak and may hinder a proper start of breastfeeding. Other infants may be irritable because they have a withdrawal syndrome, and in my opinion, even smoking in many cases leads to some sort of withdrawal in the first some days. And in this case, sedation may be appropriate. A very rare reason is malformation of the nasopharyngeal region. which will be addressed with the special issue of tongue tie in a few minutes. But in our institution, we even succeed in most cases of complete cleft to have the infants breastfed, and sometimes even without a special device from the maxillofacial department. So spontaneous sucking and breastfeeding is even possible with such a malformation. I think that most often we face poor interaction between mother and infant if breastfeeding is not successful. Mothers may have depression, and this depression is reflected by the infant. Some mothers may be reluctant to breastfeed. They may be disinterested in the infant because this was an unintended pregnancy. And these are all reasons that we have to keep in mind and have to address and to help the mothers to overcome this issue. Now, the role of the role of the lactation consultant is a very important role in the whole NICU and also in the maternity unit, and we all take much benefit from the experience of lactation consultants. And in our unit, we have regular rounds with these specialists, and so I dare to summarize a little bit of arguments that is not inherent to my personal profession as a neonatologist. We should start nurse as soon as possible after the birth, and we even try to start nursing in very premature births in infants that are born at 28 or 30 weeks. And we try to make a rendezvous after the cesarean section in the delivery room in a well-heated atmosphere to at least get a contact between mother and infant. And I personally feel that this is a very important message to do so. In the maternity unit, the midwife start a breast massage instead of using a milk pump in the first hours after birth, and this is also immediately and urgent in the first hours after birth. They look at the mothers to have enough to drink and to get adequate foods. They show how to hold the infant comfortably. They help the baby to latch, and this is very important thing. Many infants need help, tactile stimulation or something like that after birth to start adequate suckling. Now let us finally look at the issue of a tongue tie. A tongue tie is a situation that is sometimes relevant to the problem of breastfeeding. To touch that in advance, but the issue is discussed controversially among different experts, and I think that we must look at this issue. Is there an association between tongue tie and breastfeeding problems from both sides of the medal? Now, you see here the different different appearance of a tongue tie in different infants. You can see as the examination with a special spatula, but you can also use probes like this to extend the tongue and look at the underneath of the tongue. Now, what is a tongue tie? First of all, we talk about the frenulum linguae, which is an anatomic side that everybody has beneath the tongue. But if this frenulum linguis is too short or too rigid, it comes to ankyloglossia. The problem with ankyloglossia is that it is not only the appearance of the tongue, but it's also the mobility that is disturbed. The incidence is given with a great range of variation between 0.1 and 10.7% in former studies. And this even points at a very important issue, namely how to define ankyloglossia. Now let's look at a at a mode of examination that we have become familiar with in the past 3 or 4 years since we started a study on ankyloglossia. It is the so-called Hazel-Baker score. The Hazel-Baker score, or the ATLFF score, is a score that looks at the morphology and at the function of the tongue. And I do not want to go in the detail. You can find the Hazel-Baker score published in different sites of the internet. Unfortunately, the original publication was not published in a periodical, but instead of a published book. But you find the ATLFF score in the internet, and in brief, you look at the morphology of the tongue tie. You look where the tie is attached at the jawbone ridge and at the tongue. Sometimes it is at the top of the tongue, which is a very curious situation. You look at the function by lateralization. You can test the extension by using your fingertip and moving it from the lower lip to the chin. Then the infant will probably extend the tongue. You look at the encasement of suction. How well does the infant cover with his whole mouth, the nipple, and things like that are important to notice or to assess, better to say, to assess the situation of a tongue time and to assess whether this really may be relevant to breastfeeding. Now we did a prospective study. I already told you, an observational study where one single person inspected the oral cavity of all newborns in our maternity unit, and she looked at the frenulum with the ATLFF score. She asked the mothers with 8 of a breastfeeding questionnaire, and she also performed the breastfeeding scales that are published in the literature, the Ledge score and the BBET score. You can find these scores also in the net. And she also asked the mothers, how painful is lactation for you, with the aid of a numerical pain scale, and the breast was inspected. If mothers claimed that they had breastfeeding problems, they immediately received support by a certified lactation consultant. And then in a second step, the tongue tie was evaluated by the study doctor, and if she thought this might be a relevant tongue tie. Maxillofacial surgeon looked as a second specialist at this infant and did, if necessary, a frenulotomy. We did an interview 10 to 30 days later, and we repeated the breastfeeding questionnaire. And what came out from this study is that we screened 1,400 infants. Some were excluded, for instance, when we noticed that the mother was not familiar with German language or reasons like that. And we had a final cohort of 776 mother-infant diets. We noticed 116 tongue ties in this cohort, which is incredibly high number that was not reported before, 17.6%. But we also looked whether this tongue tie really made problems, and we saw that it was about 60%, not more. We had indeed about 40% of mothers that did not encounter any breastfeeding problem, even if the infant had definitely a tongue tie. On the other hand, we had, of course, mothers who claimed to have breastfeeding problems, even if their infants had no tongue tie. And if you calculate the percentage, you see that the proportion of breastfeeding problems is a little bit lower in this group than in the group with tongue tie. Now we followed them up, and of course in some infants the breastfeeding problems persisted. That was true for the subcohort without a tongue tie, but also in the group of tongue tie. Not every tongue tie was so relevant that we recommended to do a frenulotomy. But even if we recommended, some of the mothers refused to have this operation done. And you can see that if we then looked at a follow-up, if breastfeeding problems persisted, you see that some of the mothers had weaned off in the meantime. But interestingly, some of them did not report any breastfeeding problems that persisted, even if they did not a frenulotomy. So the aspect which role does the tongue tie play is not easy to assess, but interestingly, we were able to do a multivariate analysis since we had a lot of problems in our study, and we found that in fact having no breastfeeding experience, having a preterm infant between 35 and 37 weeks, and having a low birth weight infant was the most predominant factor that led to breastfeeding problems. Only in the fourth row we found tongue tie to be relevant. Now, if we then looked at the cohort with a tongue tie, again, we saw breastfeeding experience is obviously a very important issue which projects mother-infant diets from experiencing breastfeeding problems. Low birth weight, again, in combination with tongue tie, was relevant, in some special aspects of the ATLFF scores were also relevant. Now, finally, we looked at the mothers where we had recommended to do a frenulotomy. And if we asked them at follow-up what has changed after having done a frenulotomy or without frenulotomy, we saw that in the cases where the frenulotomy was done, most of the problems disappeared. But interestingly, also in the group of mothers who refused to have the frenulotomy done, some of them experienced a better breastfeeding. So we must acknowledge that the issue of an association between breastfeeding problems and ankylosing is not so clear currently. So let me summarize. It is very important to notice that having no former breastfeeding experience is a relevant issue when mothers claim that they have unsuccessful breastfeeding with their infants. And this, of course, can be overcome by a meticulous breastfeeding counseling. Breastfeeding problems can be objectivized by scores such as LEDGE and BBAT, and I very much recommend that teams in the maternity unit and in the NICU should look at these scores. It is not very difficult to apply them to mothers, and at least 2 or 3 persons in each team should have experience with these scores. And the same holds true for the ATLFF score, which gives you more safety when you try to assess the relevance of a tongue tie. Tongue time has indeed an impact on breastfeeding problems, but underweight and prematurity and issues like cesarean section do also play a role in this situation. Finally, looking at frenulotomy, yes, frenulotomy seems to be successful in many cases, but there remains concern about the proper indication, at least in units where the assessment of a tongue tie is not done by a very well standardized examination. Dear colleagues, thank you for your attention. This is my last slide, and I will switch over to the next presentation because we have the session with consecutive presentations, and then, as I told you before, the questions and answers at the end of the session. Now I hand over to Professor CILIO, who will introduce herself.
Hello, welcome everybody. Thank you very much for the nice invitation. I would have loved to be in Amsterdam. I'm a neonatal neurologist and neurophysiologist, and we'll talk to you today. We'll introduce the new findings and the new concepts in diagnosing and seizures and treating seizures in the neonates. Okay, so I would like to start from this new paper. It's the new classification of the epilepsies from the International League Against Epilepsy. This was really a new concept that was introduced, and particularly the fact that the new classification introduced etiology along each stage of the diagnosis. We are talking about the epilepsies, but also about seizures. So you can see the seizure type, epilepsy syndrome, and they emphasize the importance to consider etiology at each step of the diagnosis. And why is that? Is because it often carries significant treatment implication. So the point that I will try to bring to you today is to move out from the standardized protocol that consider seizures in the newborn as a whole and unique and disorder. But in fact, those are different disorders for which seizures are only a symptom. So the first distinction will be between acute seizures and neonatal-onset epilepsies. And the phenotype, so the electroclinical phenotype, which is the EEG characteristic and the clinical characteristic, will help us in the finding or suspecting an etiologist and choosing the appropriate treatments. So this is a nice review from Magda Nunes, from Albert Einstein in New York. We work together as a group of neonatal seizure task force of the ILA. And the goal, I mean, our aim was to see if in the literature we could find a relationship between the electroclinical phenotype, the seizure type, and the etiology. And actually come up that specific etiology of seizures in the neonates may be associated with distinct clinical features. And this can be very helpful, especially in countries that might not have video EEG availability 24/7 or genetic resources. So the specific electroclinical patterns are, for example, subclinical seizure. It's important to know that in neonates with hypoxic ischemic encephalopathy, especially the severe one, seizures are often subclinical. So we should consider this patient at risk, and this patient should be monitored either with video EEG if possible, otherwise with AEG, but they would need brain monitoring. Clonic seizure, and I will show you some examples, are very suggestive. Focal clonic seizure rhymes with acute ischemic stroke, whether focal tonic seizure is often associated, most often, very rare seizure type associated with genetic etiologies. So we also try to move on from the most common clinical practice that was in the past. So neonates at risk were monitored for clinical manifestation of seizure. If neonatologists or nurses would see a strange movement, then they would either treat directly or perform a routine EEG, which is a short EEG, maybe half an hour, which is most of the case, not really useful. And then this approach presumes that we can observe clinical manifestation every time a neonate has a seizure, and also we can discriminate between seizures and non-epileptic events, which is really not the case. So this is a baby that has been cooled, as you can see, the cooling blanket here, and she's undergoing a heart ultrasound. So this baby, as you can see, does absolutely nothing. She's a severe encephalopathic newborn, enduring a severe HIE. And so based on the current clinical practice, one might say, okay, I don't see anything, there is no suspicion of seizure. But in fact, this baby has a very prolonged, more 6 hours long status epilepticus. And you can see here, this is her EEG, 4 leads over the left, 4 leads over the right, and those are the central reads over the left and the right. And you can see a bilateral status epilepticus. This baby was never had any clinical manifestation for her seizure and turned out to have a very severe lesion from HIE. So this is another baby. This is another baby that is born at term, no problem during pregnancy and delivery, and 6 hours after birth. You can note here, as the mom and nurses did, that this baby was having an abnormal movement, which is paroxysmal, means as a sudden beginning and a sudden end. And you can define this and characterize that this is a seizure, and more specifically, a focal clonic seizure, which is pretty long, but remains confined over the left arm and hand. So this is the type of seizure that make us very suspicious and very much close to the diagnosis of stroke. In fact, this is the EEG. So we have the 4 leads over the left, and then the red is right, and then we have left and right. And you can see that the overall EEG activity is pretty good. It's a good amplitude. EEG is continuous. And you can see that over the left hemisphere, there is no there is a good brain activity, but you can see over the C4 region, which is the right central region, you can see an ictal discharge, these rhythmic spikes that become more and more higher and higher in amplitude. The seizure is long, but remains confined over the right central region. In fact, this baby had an acute ischemic stroke that was congruent with what we were seeing clinically and on the EEG. And here you see in T2, the image of the stroke that is even better seen in DWI, diffusion weighted images, and ADC. So this is a classic presentation of stroke in a term infant, and focal seizure, this is typical, were seen clinically and on EEG. EEG helped reassure that this was a limited insult. And so in this patient, clinical EEG and MRI findings were all consistent. Things are not that easy, because if you see this baby, this is a baby that has been cool and is undergoing a neurological exam. Nobody's noticing because it's difficult, because babies are in the NICU and there are other babies around and you might have an emergency going on. But as you can see here, this baby has the exactly same clinical manifestation, focal clonic seizure. This baby had a stroke during hypothermia, and without EEG monitoring, this would have been completely missed. As you can see, it's not the problem. The point is not that babies are not seen or are not cared for. This baby was undergoing a neurological exam, and you can see the same long clonic focal seizure that was completely overlooked. You can see it here. So neonatal stroke is more frequent than we think. It's one or even more case every 4,000 newborn at term. Remember that this is the first cause of hemiplegia in children. Focal clonic seizure are the most common clinical presentation, and in fact, stroke is the second cause of neonatal seizures after HIE. This is the MRI of a baby at 8 months that is brought to the child neurologist because of asymmetry in his movements. The baby was not moving well the left side. This is a delayed diagnosis. This baby had seizure possibly in the neonatal period, but were overlooked and not diagnosed and not treated. So why we said that etiology is important in terms of treating the etiology, is important in terms of treatment. If you look here, this is our paper that was published at the University of California, San Francisco, where we looked at video EEG monitoring and seizures in babies with HIE treated with hypothermia. And this paper was accompanied by a very nice review editorial from Mark Scher, talking about the importance of seizures in the era of therapeutic hypothermia. If you look at the incidence of seizures in non-cooled babies, so this was done also by the group of UCSF, you see that the incidence of seizures in babies with HIE that were not cooled was about 61%. But in our cooled babies, we only found seizure in 34%. What does it mean? It means that seizures have changed during therapeutic hypothermia, because therapeutic hypothermia treat the cause. And so the incidence of seizure, which is a symptom of a brain damage, are decreased. So treating seizure during HIE has been a long story, especially with the bumetanide that some of you might recall, and started from the search of new treatment for seizure in neonates back in 1999, when Painter presented and published this paper on New England Journal of Medicine, showing that babies, neonates with seizure, they only respond of about 50%, even when the two medications are crossed, and about 50% of children are undiagnosed. Then the idea came that phenobarbital might be ineffective. there was the idea of trying to try bumetanide. There was a study called NEMO study in Europe. But bottom line, for the past 20 years, there has been the search of new medication with the assumption that actually phenobarbital might be ineffective in seizure in neonates. And this is a very nice study published by the group of Richard Haas in University of California, San Diego, who compared finally levetiracetam, who has been one of the emergent new drug for treating seizure in the neonate, head-to-head with phenobarbital. And you can see its protocol. So the main etiology was HIE, because it's one of the main etiologies, the most important etiology for neonatal seizures. And here you have HIE and at-risk neonates, or babies in whom seizures were suspected clinically. This patient, the family consented, and they started a continuous video EEG monitoring. So what was not present in this study was indeed present in Richard Haas' study. So here was mostly clinical and short-term EEG to say whether phenobarbital or phenytoin were effective or not. But what Richard Haas' group did, they monitored from the beginning with video EEG. And so subjects were assigned randomly to IV levetiracetam, loads 40 milligram per kilo, and then additional 20, and then additional 20, or phenobarbital load 20 milligram per kilo, and then additional 20 milligram per kilo. And then otherwise, if patient was not responded, they were switched and deferred finally to institutional protocol. The results were just published 3 months ago in Pediatrics, and they were quite unexpected, and I would say amazing, especially since the study was extremely well designed and accurate. You can see the primary outcome was seizure cessation for 24 hours. This is really what we look for in the real world. And you can see that the percentage of cessation with phenobarbital was 80% and only 28% with levetiracetam. And most interestingly, as I already showed you, when they analyze they perform a sub-analysis of neonates with HIE, you can see that the response to phenobarbital was up to 90%. So the point is that phenobarbital is effective in treating seizures in neonates due to hypoxic ischemic encephalopathy. And there is a clear superiority of phenobarbital compared with levetiracetam. And this has been recently confirmed on basic research studies in a very new and very nice rat model of birth asphyxia. This was published 3 days ago, and showed that phenobarbital and midazolam, they can suppress neonatal seizure, whereas bumetanide as an add-on is ineffective, as this was proven. So this parallel well the clinical findings. But one size does not fit all. And that's why I think it's important to review our approach of seizure in neonates and treat neonates as we do as a neurologist and neurophysiologist, as we do in older children and adults. We don't treat adults with seizure all the same way. We don't treat children based only on the fact that they have seizure with the same medication and same approach. Some of them, they have generalized seizures, some of them have focal, some of them, they have absence, and we definitely don't use one size for all. In fact, talking about neonatal epilepsies, this is a paper that was published by a Japanese group of Hirose and Izumi that showed that phenobarbital and midazolam, we just said they can be very effective for HIE, but might be not effective, and not only, they might exacerbate seizures in particular form of benign familial neonatal epilepsy. So is neonatal epilepsy important, and where are we going in treating and diagnosing seizure in neonates? So we are moving from the one-size-fits-all medicine, going into stratified medicine. This is what Richard Haas has done. I only show you part of the study, the most important and relevant part for this talk. But so he divided HIE patients, stroke patients, so he stratified the patient based on the etiology. And then we can also go into precision medicine and say, okay, this particular group of etiology, and this is stratified, but we can define a particular gene, a particular mutation, and go into precision medicine treatments. So neonatal epilepsies, are these relevant? This is quite a new chapter. And back in 2017, the group of neonatal seizure registry, which put together 7 centers of pediatric and neonatal units across the US, who share the same protocols as suggested by the American Clinical Neurophysiology Society to diagnose seizures in the neonates. And so among 611 consecutive newborn with seizure, we found that 13%, which is a significant minority, didn't have acute reason, acute cause for her seizures. Seizures were not, as we say now, acute symptomatic, but they were the first symptom of a neonatal epilepsy. And interestingly, 83% of them with epileptic encephalopathy had genetic testing, and in a very high percentage, the genetic etiology was revealed. And the most common gene involved was the KCNQ2 and the KCNQ3. So is this important? I believe so. Edward Novotny writes a nice editorial to this paper suggesting that we should consider genetic testing early for neonates with epilepsy. But when should we do that? We cannot test at this point all babies. Maybe this will come later on. But we should test as early as possible, particularly in certain epilepsy phenotype. And so this is a baby that was born after a normal pregnancy and delivery. And the day 4 of life, she started to present with this type of seizure, with an asymmetric tonic posturing. You can see head goes over the left. You have an asymmetric tonic seizure that involves the left side of the body. And this asymmetric tonic stiffening, and you have a focal seizure starting on one side, and then you see ending after the focal asymmetric focal tonic seizure. You can see these few clonic jerks. This type of seizure is very particular. You don't see that in HIE, and you don't see that in stroke, and you don't see this type of seizure in neonates with infection, as an example. And you can see the seizure is short, but is followed by a pronounced postictal depression. So this baby arrived on day 4. This is the seizure. I just compacted it so you can see the seizure that is focal, then goes on the other hemisphere, becomes bilateral, and the postictal depression right after. Rose was diagnosed on day of life 4. We did an health ultrasound. We discovered that the brother had seizure in the neonatal period and was classified as intractable neonatal epilepsy. She had the interictal background was good. We diagnosed her with benign familial neonatal epilepsy and started her on carbamazepine. She was seizure-free after the first dose of oral carbamazepine, discharged the next day, and we found a novel variant in the KCNQ2 gene that was inherited by the father. So carbamazepine in the NICU is quite new. This was really not done before we published this few paper, as carbamazepine is an oral medication, and in the NICU, most people, they are used to use IV drugs. But when we reviewed an international cohort of neonates with benign familial neonatal epilepsy, familial or no familial, associated with mutation or deletion in the KCNQ2, KCNQ3, and SCN2A gene, we found that 12 of those patients actually needed many medication prior to seizure cessation. And 88% were seizure-free within hours of receiving oral carbamazepine. This was important because if you can see here, those are the cases, and this was US and Italy international collaboration, and you can see that most baby had to go through several medications, and so a high number of seizures, including status epilepticus, before becoming seizure-free on oral carbamazepine. And the one who received carbamazepine as the first drug, they became seizure-free right away. This was clearly associated with a decrease in the length of hospitalization that was significantly different. And you can see that the longer it was waited to introduce carbamazepine, or if carbamazepine was not introduced at all, the day of hospitalization were high. And as we all know, I mean, separating the baby from the family, having a baby that sees, the bad prognosis that most of us associate with the presence of seizure in the neonates is really something that if we can avoid, we definitely should. So this is another baby that has, as you can see, the same seizure type as I showed you. So it's an asymmetric tonic posturing. Here, heads, eyes are turned over the left side. You can see the tonic posturing on one side. And soon you will see another seizure with the same characteristics appearing on the other side of the body. So seizure in neonates are always focal, even when the insult or the issue is diffuse. Like in this case, this baby also has a mutation in the KCNQ2 gene. But this baby didn't have a few seizures per day. This baby had 35 seizures per hour, and she was on 7 medications. We treated her with carbamazepine, and she became completely seizure-free within hours. See again the seizure type. This is quite unique. We looked for the response to sodium channel blockers, carbamazepine, and phenytoin in this specific diagnosis, KCNQ2 benign and severe epilepsies, and found this is another international study, and found that indeed carbamazepine is effective in all KCNQ2 related epilepsy, both benign and severe form. So of course the benign have a normal interictal EEG, while the severe form, like this baby, has an EEG pattern of epileptic encephalopathy with multiple epileptic abnormalities, spikes everywhere, intermixed with period of random attenuation. But the seizure type, it's very similar. And I think if we can review the seizure semiology, we can make a very strong suspicion of diagnosis, especially if you look at the EEG and you look at seizure type prior to the administration of loads of phenobarbital, because your EEG will be clean and will be able to give you all the information you need. Most patients in these 2 studies were treated well before the results of genetic testing were available, and waiting for the results is a bottleneck in most units, even in developed countries. So consider that, because in patients with genetic epilepsy, phenobarbital is still given, loads of phenobarbital are still given, but is not only ineffective, but can also alter the background and make the diagnosis more, or the suspicion of diagnosis more difficult to make. So we said that the seizure type is specific, which is true. Here you have the seizure on the EEG, you have the flattening of the EEG when you have the tonic stiffening, and the high amplitude spikes that correlate with the seizure. You can see here the amplitudes, very high amplitude spikes, and here you have the normal amplitude background. So the spikes really stand out of the background. Seizures are short, maybe 20, 25 seconds, 50 seconds, but the post-ictal depression is really impressive, because this is something that as a neurophysiologist we are used to see in adults or in children after a prolonged generalized tonic-clonic seizure, not really a short focal seizure. But you can see, this is the next page, how deep and how profound is the depression. But this characteristic made Anna Villan, a neonatologist from Porto, made her able to identify a distinctive ictal amplitude integrated pattern in neonates with neonatal epilepsy, in newborns with neonatal epilepsies associated with KCNQ2 mutation, both benign and severe. And you can see it better here. You have the sudden rise of the lower and upper margin, and this is when you see the high amplitude spikes that last for a minute or so, and then they are followed by a marked depression of the amplitude. And this was found on most patients. And in the most recent patient of this series, the more recent patients were able to be treated with carbamazepine based on these features of the EEG, based on the semiology of the seizure, well before the genetic testing was available. And this is a nice review from the group of Ingo Elbig in Philadelphia, showing how sodium channel blockers, carbamazepine and phenytoin, are now considered an established precision medicine treatment for KCNQ2 related epilepsies. So what I wanted to bring to you today is that yes, we need improved seizure and epilepsy therapies, but what we need also is an improved and new approach that moves from the one-size-fits-all to targeted therapies, that they take in consideration the seizure type, what we call seizure semiology, and the etiology. It's true that for genetic epilepsies, the time of diagnosis is the bottleneck in many centers. And I think that this new approach with neonatal epilepsies and genetic epilepsies and the use of carbamazepine has been a game changer, because we can recognize the phenotype, we can treat early based on the recognition on the phenotype. Consider that 5 years ago, carbamazepine was barely used in neonates. And this is a path. This paved the way for a more personalized approach of seizures and epilepsies in the neonates that should deserve the same attention that we give to older children and adults. And I thank you very much for your attention.
Okay, thank you, Professor CILIO, for this very important lecture with so many new details, which I think was of great benefit for the whole audience. So I go on and I call Dr. Hannah Petersen from Berlin to talk about update on sedation and analgesia in neonates. Please.
Can you see my screen?
Yes. No, not yet.
I don't.
Not yet. Let me check again. Okay, you can see it now?
Yes.
Yes.
Perfect. Yes. Hello from
maybe
my...
I suggest maybe you can make it bigger because it's small. I don't know if you run out, how do you see it?
You only see it small?
On my size, it's full screen.
Okay. I hope you all see it in full screen.
Yeah.
Roberta, do you see it in full screen?
Yeah.
Perfect. Okay. So thank you, dear organizers, and thank you, Dr. Thorsten Uhlig, Dr. Roland HENTSCHEL, for inviting me to talk at this great conference of EIP. I've been joining last year's conferences and I really enjoyed them. So I hope this year's virtual conference will be a great success as well. And I hope all of you are in good health. And I start directly with my talk on sedation and analgesia in neonates. In the past, pain prevention and pain control has been largely underutilized due to the misconception that pain pathways in neonates or premature infants are unmyelinated or otherwise immature, and they cannot transmit painful stimuli to the brain. We now know that the age of nociception starts as early as 20 to 22 weeks of gestation, and that all prerequisites for nociception are developed in viable premature infants. So if neurophysiologic and anatomic components of pain conduction are largely developed, do they actually feel pain? And studies using near-infrared spectroscopy have demonstrated that there is an increased cortical activation in the somatosensory areas of the brain in response to painful stimuli. Goxon et al. Could also show using functional magnetic resonance imaging that there is a huge neural activity overlap between adult and infant pain, suggesting that pain experience of infants closely resembles that seen in adults. So we do have to conclude that, yes, they do feel pain. So if they do feel pain, why should we treat them? And Anand et al. Were able to demonstrate that using adequate pain management during interventions and after interventions could actually improve the post-interventional complication rate and mortality. And so we now know that interventions which reduce neonatal pain and stress can improve clinical outcomes. So another reason why we should treat them is that we know that neonatal pain may have long-term negative effects on pain response and neurodevelopmental outcome, and that repeated exposure to neonatal pain leads to permanent changes in pain processing. So we know that exposure to repetitive pain in early life may lead to a greater risk of developing increased pain sensitivity and or chronic pain syndromes. Another reason why we should treat neonates is that we know that the frequency of exposure to neonatal pain-related stress has been correlated with altered neurocognitive processing and with impairments in cognitive development. We also know that it has been shown to decrease cortical thickness and to be associated with a dysregulation of the hypothalamic pituitary adrenal axis. So now that we know why we should treat them, is it necessary or do we still hurt them? And studies which have been performed in developing and developed countries showed that neonates undergo an average of 10 to 15 painful exposures per day. And it is clear that it's the most immature infants which receive the highest number of painful events. And often these events are done without pain relief. So we do have to conclude that yes, we do still hurt them. So knowing why we should treat them and how, and that we still hurt them, we should consider on how we can assess pain in neonates. And it is clear that there's a number of different scoring systems which have been developed for neonates to assess pain. All of those scoring systems are for acute pain. And the first two, the NPAS and the Comfort Neo, are also validated for prolonged pain. And they are validated for ventilated and not ventilated infants and for premature and for term infants. And those two scales are also validated for sedation. So for now, I will cover the NPAS, the Neonatal Pain and Agitation and Sedation Scale. That scale has been proposed or invented by Hummel and et al., and it covers a part of sedation and a part on pain and agitation. It consists of 5 assessment criteria, 4 of which are behavioral, and the second is physiological with vital signs, heart rate, respiratory rate, blood pressure, and oxygen saturation. So the behavioral systems include, or assessment criteria include crying and irritability, the behavioral state, facial expression, and extremities and tones. We use the NPAS score every 4 hours and after each change in therapy or before each painful intervention. I will for now cover the part on pain and agitation, where for each assessment item, you give 0 to 2 points, and then the points are summed. So the total pain score is documented as a positive number from 0 to 10. And treatment interventions are indicated for scores bigger than 3. And the goal of treatment or intervention is a scale or a score of 3 or less. And it has been proposed to add extra points for premature infants due to their inability to behaviorally or physiologically communicate pain. The part on sedation, you give a score where the score of 0 is given for the infant's response if it is normal for the gestational age, and depending on the score or the desired level of sedation, you want a score of -10 to -5 in deep sedation, or in light sedation a score of -5 to -2. So now that we know how to assess pain, how can we actually treat it? And the first and most important, or not most important, but very important measures are non-pharmacological measures, which should always be used as a first step of pain prevention and pain control. Even if we are using opioids, we should use these non-pharmacological measures in conjunction. And there are different non-pharmacological measures which have been proven to be effective. For example, or those which have been proven to be effective, one is facilitated tucking, where the infant's legs and arms are gently kept in a flexed position, swaddling, where the infant is kept in a fabric cloth, or kangaroo care, where the infant is taken out of the incubator and put on the bare chest of mother or father. And it is known that these non-pharmacological measures work in addition, so you can use more than one, and they work even better if they're combined with, for example, oral sucrose. Other non-pharmacological measures which have been proven to be effective is non-nutritive sucking, where the infant is provided with a pacifier without providing nutrition. There it's known that sucrose, the pacifier, has a better effect. Breastfeeding is also one measure which is effective. However, there have not been any long-term studies considering psychological consequences of repeatedly pairing painful stimuli with breastfeeding. Massage has been proven to be effective as a first measure of pain control prior to heel lands, and musical therapy as well. So now let's cover pharmacological measures. The first pharmacological measure, which is really well studied and has proven to be effective for reducing procedural pain, especially from single events such as heel lands or venipuncture or intramuscular injection in both preterm and term infants, is oral sucrose. However, it did not show to alter nociceptive brain activity. And it's not completely clear how it works. In animal studies, it has been proposed that the analgesic effect is done through activation of opioid and non-opioid systems in the brainstem. However, the studies in humans are contradictory. And no optimal dose has been established. The dosings which have been proposed range from 0.012 to 0.12 gram. What we usually do is we use 0.1 to 0.2 ml of a 24% sucrose solution 2 minutes before the intervention in preterm infants, and 0.5 to 1 ml in term infants. Now let's come to local analgesia. One local analgesic is EMLA. This is a eutitic mixture of the two local anesthetics, lidocaine and prilocaine, and it acts by stabilizing the neural membrane and prevents the initiation and conduction of nerve impulses. Usually the anesthetic effect is reached after about an hour, and it lasts for about 2 hours. Based on limited data, EMLA has reduced or has shown to reduce the pain before skin breaking procedures, such as venipuncture or lumbar puncture. However, it did not reduce the pain in heel lancing. This is from a Cochrane review, which was published in 2017. And the authors say that they don't really give a clinical recommendation in infants. There's been another study published in 2019 where EMLA was used and it did show minimal effect compared to sucrose or breastfeeding. However, it didn't show, compared to placebo, but it was not more effective than sucrose or breastfeeding. Another local analgesic which can be used is lidocaine. We use it mainly in the context of chest tube placement. Lidocaine is injected locally to reduce the pain associated, for example, with venous or arterial puncture, or before lumbar puncture or chest tube placement. It inhibits axonal transmission by blocking sodium ion channels, and it exists in a 1% or 2% solution. There are needle-free devices available which can inject lidocaine subcutaneously, and they have been proven to be effective in infants or infants younger than 3 months of age. You should take care to avoid the combination of lidocaine with epinephrine to minimize the risk of tissue necrosis and tachyarrhythmias. So another analgesic which has been studied is paracetamol or acetaminophen in infants. It has been given in an oral or rectal route using different dosing regimens as high as 40 milligram per kilo, and for different interventions, including circumcision, heel lanes, vacuum extraction. However, none of these studies have shown any significant difference to placebo. There has, however, been one study which looked at the effect of post-operative paracetamol, and they were able to show that in the group which received paracetamol post-operatively, the cumulative morphine dose in the first 48 hours was 66% lower in the paracetamol group. They had included infants starting from 36 weeks of gestation, and they had given paracetamol of 7.5 milligram per kilo every 6 hours. There's another study which was performed in preterm infants, less than 32 weeks of gestation. They had included 108 infants and showed that there were no adverse events after paracetamol, and they also showed a morphine sparing effect after they had introduced paracetamol. So in the Cochrane review from 2020, the authors state that there is paucity and low quality of existing data, and it does not provide sufficient evidence to establish the role of paracetamol in reducing the effects of painful procedures in neonates. And that given after assisted vaginal birth, it even could increase the response to later painful exposures. However, paracetamol may reduce the total need for morphine following major surgery. So they pronounce it very carefully. And we can sum it up that rectal or oral paracetamol shouldn't be given in newborn infants for short procedural pain. In contrast, intravenous paracetamol can be considered for pain control in infants after major surgery. According to pharmacokinetic analysis in infants, 158 infants, doses have been proposed of a loading dose of 20 milligram per kilogram and a maintenance dose of 10 milligram per kilogram. So that brings us to opioids. Opioids are indicated for severe and acute pain, for post-operative pain, and for symptom control in palliative care. They make a positive contribution to the stabilization of critically ill children, and they alleviate hormonal and metabolic stress. We use them in the context of analgesia and for sedation, and it's really important that opioids should always be used with a loading dose, because if you don't use a loading dose, it can take hours and days until you have reached adequate plasma levels. The dose should always be titrated according to the effect, using the principle, what you need is what you get. And if you use the bolus administration, you should take 5 to 15 minutes to give it, and you should always check that blood pressure was fine beforehand. I will first cover morphine, which can be applied in a single or loading dose of 0.05 to 0.1 milligram per kilo given intravenously for about 15 minutes. Its onset of action is about 5 to 10 minutes and it lasts for about 3 to 8 hours. We usually prefer continuous infusion, or where we start with 0.01 milligram per kilo per hour and titrate according to the effect. So as mentioned before, plasma levels vary due to different metabolizing in different children, and the dose should always be titrated to the effect. So there is no absolute maximum dose. Side effects of morphine include respiratory depression, urinary retention, drop in blood pressure, a reduced gut motility, habituation, and after asphyxia and hypothermia, you should take care to reduce the dose because it often accumulates. So now I will jump to fentanyl, which you can use in a single or loading dose of 0.5 to 3 microgram per kilo intravenously. It has a faster onset of action of about less than 5 minutes and a shorter duration of action of less than 2 hours. We usually also prefer continuous administration when we start with 1 to 2 microgram per kilo per hour, and it is titrated to the effect. Side effects of fentanyl are the same as in morphine, plus it can cause thoracic rigidity, muscle rigidity, laryngospasm, and hypothermia. Compared to morphine, fentanyl has a less blood pressure lowering effect. It is less sedative and it reduces the effects on gastrointestinal motility and urinary retention. However, development of tolerance is faster and usually it has a longer withdrawal after long-term therapy. So how do we do analgesia? For neonates undergoing needle stick, we usually use non-pharmacological measures in combination with oral sucrose. For more invasive procedures such as chest tube placement, we use non-pharmacological measures plus oral sucrose plus local anesthesia such as lidocaine, and we sometimes combine it with intravenous fentanyl. And for the post-operative context, we use non-pharmacological treatment, sucrose, oral sucrose. We use opioids and we combine it with paracetamol for the first 48 hours after surgery. What can we do to avoid opioid withdrawal? You should always apply tapering principles, and there are different principles which have been published. None of them are evidence-based. We usually use the one according to Cernico, where if the opioid therapy was for less than 3 days, we usually use rapid tapering within 24 hours. If the duration of therapy was for 3 to 7 days, we do a dose reduction by 25 to 50% per day, and we discontinue the opioid therapy after 2 to 3 days. And if therapy duration was for more than 7 days, we reduce the dose for 10 to 20% per day. Another drug which can be combined or used as an adjuvant to avoid opioid withdrawal is clonidine. However, it is off-label and it can be used in single doses of 2 to 4 microgram per kilo orally every 6 hours or as continuous intravenous administration. However, you have to be aware of the blood pressure. It can cause arterial hypotension or hypertension. It can cause bradycardia and AV conduction disorders, as well as acute renal insufficiency. And of course, it's off-label. So now let's jump to the part of sedation in neonates and how we should do it. There has been a Cochrane review published in 2017 considering intravenous midazolam. And in this Cochrane review, the authors raise concerns about the safety of midazolam in newborns. The Cochrane review included 3 studies with a number of 148 patients, and 2 studies of which show an increased late onset sepsis in the intensive care unit, while 1 study showed an increased neurological consequences, such as intraventricular hemorrhage, grade 3 and 4, periventricular leukomalacia, and death. So the authors raise concern about the safety of midazolam in newborns. And there is another much older Cochrane review, which hasn't been reviewed since, which was published in 2008, where they included 13 studies with a number of 1,505 patients, and 1 study of which compared opioids directly with sedatives. In this Cochrane review, the authors conclude that if sedation is required, morphine is safer than midazolam. However, that there is insufficient evidence to recommend the routine use of opioids in mechanically ventilated infants. So, as in opioid withdrawal, clonidine can also be used as an adjunct to morphine in the context of sedation. This is a study which was conducted in Germany. It was a randomized placebo-controlled multicenter study where they included 219 children starting a gestational age of more than 37 weeks of gestation and up to an age of less than 2 years of age. They used a dose of 1 microgram per kilo per hour, and they showed a clear benefit, meaning that fentanyl and midazolam could be saved, and there were lower sedation levels and lower pain scores without any significant side effects in newborns. But again, it's off-label. So if you want to use midazolam for sedation, it can be applied in single doses of 0.1 milligram per kilo intravenously, or as a continuous infusion of 0.1 to 0.2 milligram per kilo intravenously. Side effects include drop in blood pressure, respiratory depression, neuronal apoptosis, accumulation, intraventricular hemorrhage, and periventricular leukomalacia, as well as myoclonus. Let's sum it up for sedation. Sedation should only be used, or you should use a strict indication whenever to use sedation. And before starting sedation, you should always make sure to apply adequate pain management and to make sure to use a patient-oriented stress-reduced care concept. You should make sure that in ventilated patients, there is optimal synchrony with the ventilator, and you should always use a goal-directed therapy, meaning that the level of sedation should be as low as possible. There have been many studies which have been published, animal studies, which show that anesthetics have potential toxicity for the developing brain. And it has been shown that this toxicity is mainly true for all GABA agonists and NMDA antagonists. So NMDA antagonists is, for example, ketamine. GABA agonists is propofol, chloral hydrate, benzodiazepines, sevofluran, and isofluran. And this has been shown to a much lesser degree in opioids or alpha-2 agonists, so clonidine and dexmedetomidine. That already brings me to the take-home messages. You should always make sure to use optimal handling, meaning that you should reduce noise and protect the infant from intense light. You should cluster blood drawings as much as possible. Use, for example, spring-loaded lenses for heel sticks, and prefer venipuncture to heel sticks because it's less painful. You should evaluate and score regularly using validated scoring systems. You should start pharmacological analgesia and sedation if it is indicated. And we prefer the use of opioids for pain management and sedation. while we try to avoid sedatives and hypnotics with activity on the GABA and NMDA receptor whenever possible. However, it has to be said that the dramatic results in animal studies have not been shown to this extent in human studies or in infant studies. And we should consider co-medication with non-opioids, for example, post-operative paracetamol or acetaminophen and clonidine. Thank you very much.
Thank you, Dr. Petersen, for this interesting talk on an issue that is really relevant to all of us in the NICU and in pediatrics. Now, first to the whole audience, sorry, let me first catch up on my duties as the chairman of this session. I think I forgot to introduce myself. My name is ROLAND, and I'm talking to you from Freiburg in the south of Germany. I'm a professor of pediatrics and neonatology, and I'm heading the neonatology at the University Hospital here in Freiburg. So having done that, we move on to the questions. I can see that some questions have already been collected online, and I would like to first ask Professor CILIO to identify her questions from the chat.
So the first question is, if a newborn has seizures and is controlled on current anti-epileptic drug treatments, when and how should the medication be discontinued? Well, again, it depends. If for a baby with a stroke, so acute symptomatic seizures due to stroke or HIE, the baby is well controlled, we treat aggressively and rapidly. And once the baby is controlled, usually we stop the medication before discharge. So in the clinical setting, let's say, usually seizures in HIE occur after the first 10 hours of life in the acute phase, and they are somehow auto-resolving. So they occur at the time of the acute insult. So we treat the baby, and by the time he's rewarmed, he doesn't have any more seizure. And then 2 days of 50% medication, and then we stop. So all babies with acute symptomatic seizure go home without medication, independently of the EEG findings. So what? Because those are acute symptomatic seizure. Babies with neonatal-onset epilepsy have a chronic disorder. So this is not an acute disorder, it's a chronic disorder. For example, for KCNQ2 in the benign case, I continued them on the low dose for the first year of life. And for the KCNQ2 or the more severe form of epilepsy, of course, they would go home with medication. Then which newborn seizures require acute anti-epileptic drug treatments? I would say all of them. There have been studies, particularly a nice study of Mona Todt and Linda de Vries already a few years ago, showing that the impact on brain injury measured on MRI of electrical only seizures versus seizures with clinical manifestation was exactly the same. A seizure is a seizure, so we should definitely treat all of them, both the clinical and the subclinical one. What are the further steps to be taken in the evaluation and treatment of neonates with seizures? I think most important, as I said, is to start to move forward and go away from the one size fits all and one treatment is for all. Neonatal seizure is not a diagnosis of etiology, it's a diagnosis of a symptom. It doesn't bring you more advantages than saying that a child has a fever without, irrespectfully whether it's a fever due to a malignancy or a severe bacterial disorder of a banal viral illness. So the next step is to move forward with stratification based on the etiology, identifying best treatments, and even for epilepsy. And I just say that in a few words, but if you think about the epileptic encephalopathies, the old definition like Otahara syndrome, those were described in 1972, 1978, when there was basically there were no MRI, no genetic testing. So the next step is to parsing this old syndrome like Otahara syndrome in more etiology specific condition. And then I see a question for Hannah.
Yeah, what kind of analgesia do you use in the context of palliative care if you do not have an IV access? We have those cases where we do primary palliative care in the delivery room, and we usually use fentanyl intranasally. It's also off-label, but you can use it in the same dosage as the intravenous, so 2 to 3 microgram per kilo, and you can use the standard IV solution. Usually you have adequate pain relief after 5 to 10 minutes, and you can also titrate it according to the effect.
And then I have, in terms of treatments of neonate with epilepsy, is the ketogenic diet an option for this age group as well? Or are treatment mostly pharmacological? So this is really a very good question. So most of them are pharmacological treatments, but we are learning how to use more and more ketogenic diets in neonates. Sometimes it's easier than in older children because one can use the KetoCal, which is already prepared milk for neonates that we want to introduce with ketogenic diets. I think that ketogenic diet could be considered, especially when drugs do not work, or when the patient might have other issue that might prevent the use of a given anti-seizure medication, is a treatment, and it should be considered. It's not very much used, so I cannot tell you how, what is the response, but for some disorder, for example, neonatal epilepsy is an epileptic encephalopathy due to STXBP1 gene, in which you have spasms in neonates. This could be definitely an option.
Okay, once again, a question for Hannah.
Are there studies regarding the use of ibuprofen or metamizole in neonates? No, the studies which have been performed using ibuprofen are only for closure of the patent duct, and there are no studies for other non-steroidal anti-inflammatory drugs in the context of analgesia. And probably there also will be not any studies because the company don't have any interests in performing those studies, and it would be interesting to do a study concerning ibuprofen, but there haven't been any studies concerning analgesia in neonates.
Yes, because we probably most of you will have noticed a study that was recently published that showed ibuprofen versus paracetamol is superior in terms of pain reduction, but this was a study that was done in older pediatric patients. This is a very important message to all pediatricians who prescribe peripheral analgesics to pediatric patients. Ibuprofen seems to be superior to paracetamol, which is, at least in Germany, the most often prescribed drug for low-level pain in pediatric patients. Okay, we have time for some more questions. If you wish to comment or ask questions to the speakers, may I ask you, Hannah, about the NPAS score? Are you aware of the age range which was used in the validation procedure of this score? what is the lowest gestational age or the postmenstrual age that obviously this score is suited for?
I think it was validated starting from 24 weeks of gestation.
Okay, so it offers a lot of opportunities for those who work on the NICU to assess patients according to this score.
Yeah, if you work in a NICU where also older patients are treated, then the other one, the Comfort Neo scale, is also good because it is also used in older children for the Comfort B scale. So you could use the same scale for NICU patients and older patients. But if you don't have that, then the NPAS is the score we use.
Mm-hmm. Another comment, or yeah.
I would have a question for Hannah.
Yeah.
Is there any sense, or do you in clinical practice use to combine two drugs for analgesia and sedation? I'll take an example, the infants with HIE, especially the mild encephalopathy. So the ones that are not like the first baby I showed that was not moving, severe encephalopathy, but the ones that are less severe, they do not tolerate well being on 33.5 degrees. And so that's when fentanyl or morphine is used. But do you use combination, let's say low dose morphine, low dose midazolam, or is one drug better than another?
We use morphine. If that's not enough, then we also use clonidine. And if that's still not enough, then we would use low dose midazolam.
When you use clonidine, you use both?
We always use morphine.
And clonidine.
And clonidine if morphine is not enough. And sorry, now I don't hear anything.
Oh, sorry, no, I mean clonidine would be an add-on.
Yes, adjunct, yeah.
Thank you.
You're welcome.
May I ask you, Professor CILIO, about a topic that is really relevant to pediatric intensivists and neonatologists? Dr. Peterson told us that there are data on neuronal apoptosis for midazolam. On the other hand, she had a slide where she summarized data on animal studies about different kinds of anesthetic or sedative drugs. And on this list, I found the old-fashioned phenobarbital. I'm always asked by young doctors why we still use phenobarbital. But if I now see that even midazolam, which is used more often in infants, has probably the problem of neuronal apoptosis. Do you have any further evidence to weight one drug against the other, Professor CILIO?
Oh, thank you. So for me, it's really a question of which drug is effective in a specific type of seizure and etiology. Why do we still use phenobarbital in HIE? Because it's effective. And I think that, and same for midazolam, but I think that translating basic research findings into clinical practice, it's always a good thing to try, but it's not always a perfect translation. The bumetanide story, I think it's an important one. So the bumetanide story was based on the fact that benzodiazepine and phenobarbital are GABAergic. And in the neonatal brain, again, basic research studies by Francis Jensen, Boston Children's Hospital back in the 90s, had shown that GABA in the neonatal brain is not an inhibitory neurotransmitter, but is an excitatory neurotransmitter. So based on that, was the story phenobarbital and midazolam are not effective because are GABAergic, and the neonatal brain use GABA as excitatory. So there was the study of the group in France that showed, again on basic research, that the chlorides is the type of receptor that turns neurons from immature, so GABA excitatory, into mature, and so GABA inhibitory. And so bumetanide was supposed to switch neurons from immature to mature so that phenobarbital could be effective. So this was all based on the GABA excitatory in the neonatal brain. It's clear that bumetanide do not work, does not help phenobarbital to work. And I think the study that has been, a long and an NIH funding study of Richard Haas has shown that phenobarbital stops seizure, at least in neonates with HIV. And I think this is the reason why we use it.
Okay, thank you for this clear statement. I do not see any further questions. If you agree, it would be my task to finish the session, and I thank you. I thank all attendees all over the world who took the opportunity to join us this morning. We all hope that you took benefit from this session on neonatology. And I would like to remind you that you have a privilege to look at other sessions that have run in parallel later this day or even in the past few days. This is, if you have subscribed to the EIP meeting, you can see all other interesting sessions later on. So finally, let me say we all hope that next year we will see you live at the next EIP Congress, where it will be our pleasure to come in contact with you without any distance regulations. And I say goodbye. Have a good day.
Thank you. Thank you very much. Thank you all.
Thank you for joining.